Hello everyone, it's Schematic Med, and today we're going to discuss the diagnostic strategy and management of suspected pulmonary embolism. At first, it may seem a little difficult, but we will discuss everything very thoroughly. When patients present with pruritic chest pain, dyspnea, tachycardia, and tachypnea, we suspect pulmonary embolism. If we're going forward and trying to diagnose, we need to stabilize the patient with oxygen and IV fluids. Next step is evaluate for absolute contraindications to anticoagulation. Here we see the management when we have no anticoagulation contraindication. It is impossible to talk about pulmonary embolism management without talking about modified Wells criteria. These criteria will give us the pretest probability of pulmonary embolism. This is very important and we need to know the criteria and the points. So, clinical signs of DVT or deep venous thrombosis will give us 3 points. If alternate diagnosis is less likely than PE, that will give 3 points. Previous pulmonary embolism or DVT, 1.5 point. If the heart rate is more than 100, again we will add 1.5 point. If patient had recent surgery, approximately 4 weeks, or immobilization, we will add 1.5 points. Hemoptysis is 1 point and cancer is 1 point. The total can be 4 and less, PE is unlikely, and more than 4, PE is likely. Maximum is 12.5 points. So one more time, I want you to remember we're talking about when we don't have any anticoagulation contraindications. We will start with modified Wells criteria, because if we have contraindications, we will go straight to the diagnostic tests. Now, if we have 4 and less points, it means PE is unlikely. We already gave oxygen and IV fluids. If PE is unlikely after modified Wells criteria, we still cannot be sure and cannot confirm that we don't have PE. We need to check the dimer level. If the dimer is 500 and less nanogram milliliters, it means we don't have PE. If it is more than 500 nanogram milliliters, we need to do pulmonary CT with angiography. Let's stop here and go back when modified Wells criteria will give us more than 4 points, which means PE is likely. And if patient has moderate or severe distress and we can give anticoagulation, we will start giving empiric anticoagulants. Checking the dimer is not useful when we already determined that PE is likely. And if the patient is stable, the test of choice is pulmonary CT with angiography. Again, let's stop here. Let's repeat one more time. The test of choice for pulmonary embolism confirmation is pulmonary CT with angiography. And additionally, we will start from this point and we will do pulmonary CT and angiography if our patient has contraindications to anticoagulation. If PE is confirmed, we will continue anticoagulation, but if we didn't start it empirically, we will start anticoagulation. We can do surgery or thrombolysis. And if we have any contraindications, we will consider IVC filter replacement. But if CT says that we don't have PE, we will stop anticoagulation if we start it, and we can say that we don't have PE. One little thing that I want to add, when PE is likely and we give empirical anticoagulation, that can decrease the mortality. Thank you, bye.